Hi, I'm Dena Baker. I'm a graduate student at West Texas A&M University. Today we're going to be talking about groin management and vascular closure devices. The reason I've chosen this topic is because my project has been over the vulnerable population of repeat interventional patients that return to the cath lab, trying to troubleshoot exactly what's going on with these patients. So today we're just going to focus on vascular closure, looking at groin sites, things like that. The complications with these procedures typically come at the end of the procedure, so going over this, understanding what's going on, would help you be more effective in the cath lab. I have a projector set up for you there, so if you just look behind you, you'll be able to see what I see on my iPad. I have a laser here, so I'll be able to point out to you exactly landmarks and things like that that we're looking at during our procedure. At the end of my presentation, I'm hoping that we'll have enough time that I can actually go over a closure device with you, see how that works, understand the mechanisms behind that. If you have any questions at all during the this educational portion, just holler it out. This is very informal, going to last about 15 minutes. Okay, we're going to start off with why we choose the femoral artery to access when we do procedures to begin with. Honestly, the femoral artery is the quickest and the largest vessel to access. We're seeing an increase in radial interventions. That the radial artery is not as large as the femoral. The comfort in going radial is patients tend to recover quicker. They don't have to lay flat. They can put just a hemoband around that site to stop the bleeding. So patients kind of prefer that. Physicians like it because the complication rate goes down because of closure devices. There is still the reasoning behind not going radial is sometimes people don't have a good radial pulse. Sometimes the radial vein will contract and won't allow you to advance a sheath. So femoral access is still popular and a backup. So that's the reason why we go femoral most of the time. Closure is important. If you don't close an artery, if you've done an intervention, the patient usually has to go back to the unit. They have to go back with a sheath. You have to monitor PT-INR. You have to monitor an ACT. You have to monitor, make sure their blood thickens up before you pull a sheath, and then somebody has to pull that sheath and hold pressure. So of course, a closure device is a great thing. It can decrease that patient downtime. It can decrease the discomfort of laying with a sandbag on your groin, things like that. So it's beneficial to the patient and to the staffing because you can get those patients up, moving around, get them out sooner. The problem with vascular closure devices is complications. You can get a hematoma. I'm sure all of you have seen hematomas. Not fun. Compress them out. They typically do well with that. Pseudoaneurysm, which is a false pocket around the vessel that forms. Those typically have to be compressed by ultrasound. They're not compressed by staff. Typically, they're hard to target. And a retroperitoneal bleed. As a nurse, you need to make sure that you're constantly checking and listening to what the patient says. What's going on? What are they feeling? Watching those vital signs, checking the site, things like that. Because an RPB can be difficult to determine, and once you do determine that, sometimes it's too late and they're off to surgery. So we're going to talk. If you look up at the presentation, you can see there's a landmark. You see a femoral angiogram and you see a femoral head. Well, with vascular closure, you want to make sure that you're targeting that midsection of the femoral head. That ensures that when you're holding pressure on that artery, that you have a compression site. If you hold too high or too low, you're not going to have anything to compress that vessel up and stop that bleeding. So the femoral head is a great target area when you're looking under fluoro to see the femoral head right there. The other thing is you have an inguinal ligament that runs through there. You can't see that under fluoro. You can't see that when you're checking the x-ray and doing the procedure. What you can see, however, when you do an angiogram, which anytime you do any closure device, you should do a femoral angiogram. That ensures the safety of the closure device. So you can see right there the clean femoral angiogram. You see a bifurcation right here. That is going to be your SFA, your superficial femoral artery, and then that's your profunder going up there. And you see that little sweep right there that's going to the medial side to the patient? That little sweep is your inferior epigastric artery. So when you see that little sweep there, most of the time you're not going to use a closure device if you're above that little V section right there. I'm pointing to it right now. if you're above that sweep, you tend to be, if you notice on that next picture, right next to it, that the body, the way the body is designed, that the natural way the body is that artery is going to flow down. It's going to actually dive into the body. So if you're thinking about closure, you don't want to close something that's too high, because the vessel actually dives down and your complication rate for that RPV, that retroperitoneal bleed, increases tenfold. So ensure that when you're in the procedure and they're looking at closure, is that a good one or not? That's a main key point. The other thing is to ensure that the vessel is at least 5 millimeters wide. I'm videotaping. Is at least 5 millimeters wide to ensure that the closure is successful. In that, if it's not that big, you could have complications with pulling a balloon back. Any closure, they need to have a vessel at least that big. The other thing is disease. You see this one right here, this next picture I have? You see that right there? All that's calcification, and that's disease in the process. And those are difficult and groins that you typically should walk away from. Okay. Another thing here is another angiogram is a bifurcation. Right here you can see right there is the SFA and the profunda. Some closures actually will close if you're in the SFA. Some closure is contraindicated. So just ensure whatever closure device that the physician is reaching for, that you kind of know and understand exactly what their IFU says, their information guide, to ensure that you're protected in using that closure. Okay. Locating the femoral artery, you're going to notice in the procedure to begin with that they are targeting that when they put the drape on. They're targeting that area to ensure that it's within the sterile procedure area. That helps you, but ensure that you do fluoro on top of that to make sure that you see that bony, that femoral head, that it's in the area that you're going to stick. Again, here's another picture where you see the common femoral head, and you want to make sure that just for your compression area that you, like I said, are in the middle of that femoral head. Ensure once again that every closure is precipitated by a femoral angiogram. That covers not only the staff and the physician, but the patient as well. You don't want to close something that you're not going to be successful or create a lot of pain. Okay, let's look at some more pictures. Here's another angiogram. This one looks pretty clear. It's pretty big. It's between 5 and 7 millimeters. You're right at the bifurcation, and there is a closure device out there that is indicated for the bifurcation. Some are not. The particular closure device that we're going to be looking at in a minute is indicated for the bifurcation, the SFA here, the perineal you can do as well, and you can even do antegrade sticks. So excellent choice for closure. One thing you got to realize when you're performing post-assessment and you're looking at the side and you're beginning to see some complications arise, if there's been multiple sticks during the procedure, those are going to be complicated groins to close. So ensure that when you're at the bedside table or during the procedure, if you notice the physician is having difficulty getting access, if he's doing multiple sticks to get access, that those are things you know maybe to pass on to your report to the nurses that are taking that patient to recovery, that maybe they should be watching that groin a little more. We talked about high sticks and low sticks and location of the vessel. Let's talk about some different closure devices that are on the market. Okay, there's a suture that's left behind permanently in the vessel, and that's called a perclose. That actually, they actually put the stitch in, tie it off, and tie that vessel off. The problem with that closure is that sometimes you can actually cinch the entire vessel through. The good thing about it is you can check for hemostasis almost immediately. You can have the patient flex their leg and check to see if there's any bleeding or oozing. Another closure device that is highly used is called the angioseal, and it actually has a foot plate that sandwiches up against the arteriotomy, and a collagen plug is deployed, and then a suture is left behind. That is actually that is actually absorbed in 90 days or less. This is typically a very secure close. You can trust that the patient will do well. The complications that arise from that, again, can be bleeding, hematoma. The reason that you need to be aware of this device is that foot plate can sometimes catch on calcium. Sometimes it can actually break off and be deployed downstream. That is not a good complication to have. The closure device that we're going to look at today is actually called the Minx Grip. It actually is an extravascular closure device that sits on top of the vessel. It's safer for the patient if something's not left behind in the body. So it's rational to say that extravascular in itself is going to be safer and better for the patient. This actually is virtually pain-free. Most patients don't even know they're receiving the closure, and it goes through your existing sheath. So for those of you who haven't seen a sheath before, this is a sheath. When you spend time in the cath lab, you're going to notice these. This is what they put into the artery when they go in. It actually has a dilator. The dilator will come out. There's a one-way valve to stop bleeding when it's in the body, and allows you to enter and take out different sheaths during the procedure. So with this, we're going to go ahead and put this sheath. This is assimilating the body. Where it comes out here is simulating the interior of the artery. So we're just going to take that out like this. This closure device actually has a balloon that you use to pull back to the arteriotomy to help with temporary hemostasis. This is what the device looks like. So we're going to take some saline. If you want, you can use some contrast in this. This device is the only device on the market that offers you the ability to visualize it under fluoro. So you can put 70% saline and 30% contrast in your balloon, and that's what we're going to do today. So you're just going to pull a negative, you're going to test your balloon, you're going to ensure that the balloon inflates all the way, and that you're going to ensure that this indicator at the end of the device is properly retracting. Okay, with this device has an atraumatic tipped wire, so we're going to insert this wire through your existing sheath. So help up real close, sometimes it's kind of hard to get it in. So we're going to advance this wire to this white marker. This ensures that we've cleared the distal end of the sheath. We're going to inflate this balloon, turn your stopcock off. Right hand, black handle, we're going to pull back. At this point, you're going to fill the first stop, which is the distal end of the sheath. The second stop is the arteriotomy. So in order to ensure that you're safe and we have temporary hemostasis, I want you to loosen up your hand a little bit. Open this stopcock. You should have blood return through your the hub of your sheath. When you pull back, just that right amount of tension, there's not going to be any more bleed back through this port. So that ensures that you have that temporary hemostasis. At this point, you're going to shuttle down your green handle all the way through. You're going to pull back the sheath, revealing this white compression tube. You're going to advance that just enough. We're going to force that sealant onto the vessel. So you're going to hold this device for 30 seconds. Okay, let's say it's been 30 seconds. We're going to lay the device down. At this point, that balloon actually floats back into the vessel a little bit. That's okay because you want that. You want the blood in the body to swell that sealant. Actually, 3 to 4 times is what they say this sealant swells. So we're going to pull a negative on this device. We're going to deflate the balloon in order to remove the balloon from the body. We're going to keep this white tube here so that we can keep that sealant pushed against the vessel. We're going to remove and we're going to hold some pressure here. Should just be 30 seconds to, or 60 seconds to 2 minutes or so. Hold some pressure. Make sure you put a 4x4 and a tegaderm on this. Ensure that your patients understand what vascular closure device that they've received so that they are properly educated as to what's taking place. Dressing should stay on for 24 hours, really not anything more than that. It's not conducive for hygiene. You could actually get an infection from leaving the tegaderm on too long. So tell them 24 hours, take it off. They need to, while they're in recovery area, to keep their head against the pillow, leg against the stretcher to ensure that there's no bleeding. Education should go home with the patient. If they have any complications, they should contact the physician who's in charge of their care. At that point, follow-up should always be recommended to check a groin post-procedure. So if you have any questions, I'm free. If not, why don't y'all come up we'll just stand around the table and work on the device, see how